complement attack. Okay, complement lysis. You still remember what is a complement protein? So complement proteins are part of our immune system na para pag may pumasok na organism sa atin, i-coat nila yun, tapos puputasin nila yung membrane. Diba? Puputasin yung protein. So that is the action of the complement system in our immune system. Okay, now, so if the complement is activated, our red cells should be protected. So we have a protective gear so that if the complement is activated, our red blood cells will not be lying or magkakaroon ng collateral damage. No? So unfortunately, in a PNH red cells, so it is activated or it is destroyed by complement lysine. So kaya pagka PNH, ang tawag natin dyan ay complement-dependent hemolysis. Okay? Complement-dependent. Without the presence or activation of the complement, even though your red cells don't have CD markers, then the red cells will not be lysed. Kaya complement dapat. Now, we will try to activate the complement so that we will lyse the red cell. Kung may suspecto tayo na yung pasyente natin mayroong PNH. So that's why we have tests such as sugar water, sucrose hemolysis, and the HAMS test. So the objective of this test is to activate the complement and then allowing the red cells to be lysed. Kung walang CD55-59, malalyse nga. Naintindihan ba? Yan. Okay, now between the three tests, sugar, water, and sucrose hemolysis is considered to be the screening test. So it's not a specific test or confirmatory test. Screening test sila. So ang confirmatory test will be the HAMS test. Yan. Now, other tests that will confirm PNH is yung gumagamit tayo ng flow cytometry. Okay? Flow cytometry is the use of an automated machine wherein you can quantify the number or the CD markers, quantify the CD markers in a cell. So the principle of the flow cytometry will be discussed sa inyo pagkatating nyo na sa automation. Basta, meron tayong mga automated machines na ganyan. That will confirm. Okay, so kaya dalawang confirmatory test natin for PNH, with the use of flow cytometry, and then we have the HAMS test. Now, so what is the principle of sugar, water, and sucrose hemolysis test? What are the things that we mix there? So again, sabi ko sa inyo, i-activate natin yung complement. So ano pwedeng magpa-activate at magpa-allow ng attachment ng complement sa red blood cell? If the environment of the red cells are having sugar, kaya nga sugar, water, at saka sucrose, so yung complement magbabind sa red blood cell. Okay? So, ipag-mix natin, sugar solution, yung table sugar na ininigyan ng sa water, puganawin, tapos lalagyan ng RBC, tapos lalagyan ng serum. So, the serum is the source of the complement protein. So, yun ang mga mixture. Etong sucrose, ganun din, kaya lang ang sugar na ginagamit dito, yung sucrose na mismo. Sugar, sucrose, then the red blood cell, and then the serum. So the end point of that will be hemolysis if there is a PNH red cells. Hindi ba? So pag sabi natin PNH red cell, walang CD55, walang CD59. Hindi ba? Yan. So anong end point? Hemolysis. Kaya dito sa tatlong pasyente, sino dito ang possibly na merong PNH? Of course, this one. Kasi nalayis yung kanyang mga red cells. Hindi ba? Ganun lang yun. So this is a screening because it is sensitive only to PNH. Because there are also other disorders that may cause positive result in sugar, water, or sucrose hemolysis test. Like for example, the patient has leukemia, baka mag-positive yan. So kaya pag nag-positive dito sa dalawang ito, so we have to confirm and go now to the HAMS test or flow cytometry. So what is the principle of the HAMS test? So it is also known as acidified serum test. So mapapansin niyo here, we have three different serum preparation. We have the patient serum, yung pasyente mismo, wala natin ang serum. Then we have normal serum, galing sa ibang tao. And then we have the inactivated serum. So how do we prepare inactivated serum? So we have to heat that at 56 degrees Celsius for 30 minutes. Okay? So heat treatment. treatment. So the main objective of inactivation is to destroy the complement activity. So masisira yung complement. So wala nang complement dito. Di ba? Pero yung sa normal serum, sa patient serum, so syempre, nandiyan pa yung complement. So meron ka ng serum preparation, and then you will now acidify it. So we add acids such as hydrochloric acid. And then after we acidify it, then we add now 20 UL of blood. 20 UL. So lagyan natin yan. Now, if the patient do have PNH, the expected result is like this. There will be hemolysis of patient's serum or normal serum. While there is no hemolysis doon sa inactivated serum. Why is it that walang hemolysis dito? Kasi nga wala yung complement. Remember, PNH is complement-dependent lysis. So dito sa dalawa, nandito pa yung complement. Diba? And that's why you can confirm, no? Yung ating PNH using this test. Now, but there are also other results that we may encounter, such as like this. For example, patient serum, walang hemolysis, pero the other serum preparation may hemolysis. Then we can see it in this kind of disorder known as CDA type 2. So what is the meaning of CDA? Congenital dyserythropoietic anemia. No? So we have 3 types. So type 1, type 2, type 3. Other term for CDA type 2 is HEMPAS. Okay? Ano yung sabihin ng HEMPAS? May HEMPAS mo. So yan. So ano yung HEMPAS? Hereditary erythroblastic multinuclearity and positive acidified cell. Okay? Tama ba yun? Hereditary erythroblast with multinucleus or multinuclearity and positive acidified cell. So we have 3 types, no? Kaya pag tinanong sa inyo, ano yung type na may HEMPAS or HEMPAS type? Yan. So ano na may iba pang possible result na may encounter natin sa hamsters? Ito, not may hemolysis. So we see that in hereditary dysbiocytosis. Okay? So that's why there are 3 disorders that will show lysis after we in making or doing hamsters. So what are those 3 disorders? PNH, CDA type 2, and hereditary spherocytes. Okay, but hereditary spherocyte is not a test, or it is not the disease confirming or confirmed by hamsters. Yan. Para sa hamsters talaga, para sa PNH. So ano ang test natin para sa hereditary spherocytosis? Ito yun, no? So EOFT and acyl fibromalumine binding test. So we just focus on the EOFT study. So what is the meaning of EOFT? Erythrocyte osmotic fragility testing. So from the word itself, we are testing that if the red blood cell is fragile, yung kanyang membrane, kaya nga fragility testing. So what is the principle of this? So but before that, what is the problem with hereditary spherocytosis? It's a genetic problem wherein the membrane of the red cells, the protein, specifically the spectrin, okay, what else? Ano bang problema? Ankyrin, what else? Protein band 4.2 and protein band 3. So these are the membrane proteins that are defective in our RBCs. That's why your red cells become spherocytic. So how does it become spherocytic? Naalala niyo yung discussion natin during our first so ano nangyari? Nagkakaroon ng plebs. Naalala niyo ba yun? Nagkakaroon yung mga protrusion, yung ating mga red blood cells. Lose nga yung membrane. At pagpunta nito sa spleen, diba kinakain ng macrophage, acid, natanggal nila yung plebs na yun ng ating mga red cells. So the consequence of that, our red cells is losing membrane. And then eventually it becomes small, nagiging spherocytic. Ang kanyang diameter usually is less than or equal to 5 micrometer. So that's why if you see in your exams that the red cell size is like that, then it is small because the minimum is what? Okay, minimum is 6. Average is 7, 7.2, 7.5. So pero ang minimum na base mo na okay ko yung red cell size mo ay 6 RBC, masyadong siksika na yung hemoglobin sa loob kasi nga yung surface area to volume ratio is decreased. So this kind of red cells is losing its deformability, especially if it bumps the blood vessel wall. It may burst immediately or maybe mag-bumps sa mga heart valve natin, it will burst. Kasi nga, masyado ng matipot o masyado, parang balloon, no? Pagka sobrang dami na ng tubig, stretch na masyado, kaya pag kami na sumutulog agad. Diba? So, ganun ang nangyayari sa mga red cells na spherocytic. Now, so, we want to check kung meron bang spherocytic red cells nga yung ating pasyente. So, we can subject it into an EOFD study. So, the principle of the EOFD is we have to prepare several concentration of salt from hypertonic to hypotonic one. In your biochemistry or in your chemistry, it was taught to you that if you put a cell in a hypertonic solution, what happened to your cell? It shrinks or swells?
Yes.
Okay, it shrinks. Hindi ba? Yan. Pero pag nilagay mo sa hypotonic solution, pag-swell and then mag-burst. Yan. Okay, now, so our blood will be subjected into this, no? Then we will check what concentration of salt na burst yung ating RBC. A normal red cell dapat magkaroon ng bursting or malaise, no? Starting at 0.40 to 0.45%. If that is the case, we call it partial hemolysis. So partial hemolysis is the first test tube we see na meron ng hemolysis, tapos meron pang mga red blood cell na natira. So ang normal na red cell magsisimulang malaise at that salt concentration. So meaning that it can still withstand a hypotonic solution of 0.5% sodium chloride pag normal na red cell. Okay? At ang normal na red cell magkakaroon ng complete hemolysis at 0.30 to 0.35%. Ano ibig sabihin ng complete hemolysis? Lahat ng red cell pumutok na. Yan. So, yan yung huwag yung kakalimutan, yung reference value of our EOFT. So, that's why if your result is like this, no? 0.75, meron ng hemolysis. So, ibig sabihin, early, na-hemolyze na, so baka meron kang hereditary spherocytosis. Yan ba? And, so, ganun lang kasimple yun, no? Now, so, but there are also other poikilocyte that shares the same result with spherocytes. Now, what do you call if you say poikilocyte? What is the meaning of that? Okay, variation in the shape of the red cell. Okay, so pumuputok din ka ganito mga red cells na to. One of that is macrophagocytes. Okay, macrophagocyte. So, ano yung tsura ng mga macrocytes or macrophagocytes? So, parang egg, no? Yung appearance ng ating mga red cells, lumalaki sila, tapos wala na rin central pallor. So, what happened here is that madali rin pumutok yan. Kasi pag pumasok yung fluid dyan, ilagay mo sa hypotonic solution, pumutok agad, parang spherocytes. Ganyan? Okay, now, so what example of disorders wherein we see these macrocytes or macrophagocytes? So we see this usually in megaloblastic anemia. Okay, we see that in megaloblastic. Kaya ang pangalan niya mega, no? Kasi lumalaki yung mga cells, no? Lumalaki yung ating RBCs. Okay, we see macrocytes, macrophagocytes. Okay, now, what condition or what is the reason why you develop megaloblastic anemia? Maybe because you are lacking these important nutrients which are vitamin B12 and folate or folate. So, pwede combine, no? Meron tayong tinatawag na ganun, combine vitamin B12 and folate deficiency. Okay? Now, so it may lead to megaloblastic anemia. So, for example, you are lacking vitamin B12 in your body. So there are a lot of conditions that will lead to vitamin B12 deficiency. So one of that is pernicious anemia. Okay? Okay, so pernicious anemia, no? Now, intrinsic pa, vitamin B12, para ma-absorb natin sa intestine natin, kailangan natin ng isang component known as intrinsic factor. Okay, intrinsic factor is synthesized by the parietal cells of our stomach. No? Without this, we cannot absorb vitamin B12 properly in our small intestine. And kapag tinanong sa inyo, anong problema ng pernicious anemia? Wala kang intrinsic factor, problema ka sa intrinsic factor, kaya ang consequence nun, hindi mo ma-absorb yung vitamin B12. Kumain ka ng itlog, sabi nila maraming may vitamin B12 yung itlog. Kumain ka ng dalawang itlog, no? Pero dahil wala kang intrinsic factor, so hindi mo ma-absorb yung itlog. Kaya yung itlog, yung vitamin B12. Okay? Diba? Yan. So yun, no? Now, so that's why if you have this pernicious anemia and you subject his or her blood into an EOFD study, what is the expected result? Increase ang sensitivity. Pag sabi natin increase sensitivity, puputok ka agad pag nilagay natin sa mga hypotonic solution. Naintindihan ba? Okay. Now what else? Ano bang poikilocyte na ganun din, pumuputok din kagad? One of that is elliptocytosis. Okay, ito naman parang ellipsoidal or cigar-shaped appearance of our red cell, and this is simply hereditary elliptocytosis. Okay, hereditary elliptocytosis. What is the problem with hereditary elliptocytosis? This is the problem of protein band 4.1. Okay, protein band 4.1. So yan, no? Pumuputok ka agad. Okay, kunwari tinanong ko sa inyo sa midterm exams niyo, the complete, the partial hemolysis result of the EOFD is at 0.30 to 0.35%. Is that normal?
Yes.
Partial hemolysis sinabi ko. No, kasi dapat complete yun. Yan, complete hemolysis. Eh, doon pa lang nag-i-start malize yung red cell sa 0.30 to 0.35, hindi dapat. Saan mag-i-start dapat? 0.40 to 0.45. So meaning, anong meron sa specimen ng pasyente? O bakit ganun ang red cell niya hindi kagad naputok? So baka meron mga tinatawag na non-lysing RBCs. Okay? So non-lysing RBCs. So you will think of what are those poikilocytes that has non-lysing RBC. So one of that is target cell. Okay, target cell. Other name of target cell? Podocyte. Other name of podocyte? Okay, Mexican heart cell. Okay, Mexican heart cell. Diba? So yan yung mga different names of our non-lysing RBCs. Now, so bakit tinawag na target cell na ulito? Kasi ang itsura ng RBC natin ay ganyan, no? Nandito yung hemoglobin sa gilid, tapos nag-concentrate sa gitna. Kaya tawag target cell. Is that normal appearance of your cell? Of course, hindi. Ano dapat na nasa gitna? Central pallor. Now, so because of this problem that we have in our cells, so if you subject this into a hypotonic solution, the fluid will go inside, okay, but because still there are a lot of space, hindi kagad puputok. May space pa eh, to accommodate the fluid that enters. Unlike the spirocytes, pagpasok ng fluid, putok kagad, kasi wala nang space eh. Yan, they are fragile. So ito hindi fragile. O ba? So saan mga disorders pwede tayong makakita at common ang target cells? So sagot nyo ay thalassemia at saka hemoglobinopathies. Okay? So thalassemia and hemoglobinopathies. That is where we see this target cell. But there are also other conditions, no? Pwede rin tayo makita ng target cell. Okay, what else? Ano pa yung mga non-lysing RBC? One is hypochromic RBCs. Okay, hypochromic. So how can you say that you have a hypochromic red cell? Okay, ang laki ng central pallor. Ano dapat ang size ng central pallor lang? 30 to 45% of the total diameter, 1/3 or less than 3 micrometer ang diameter ng central pallor. So central valor. No? Pagka nakita mo gano'n, sa reporting mo, may hypochromic red cell. Pagka gano'n kasi, napaka-konti ng hemoglobin na nasa loob ng red cells. Kaya pag pumasok yung fluid inside, so marami kang fluid na pwede ma-accommodate because the surface area volume is increased. Okay? So what are those different conditions wherein you see hypochromic red cells? Sa mga condition? Apat yung nasa utak nyo dapat. No? Okay, iron deficiency anemia, thalassemia, anemia of chronic disease, and sideroblastic anemia. Okay? Sideroblastic anemia. These are the 4 conditions. That's why if we reported it to the doctors, no, na nag-investigate ng anemia, sabi mo, hypochromic yung RBC ng pasyente. So, apat gamit yung nasa utak niya. Ngayon, kung babae yun, kadalasan 98 na yun. Pero pag lalaki, thalassemia ang iniisip ng doktor. No? Okay? Yan. So, may target cell, meron pa, hypochromic RBCs. What else? Ano ba? Non-lysing RBC, mga sickle cells. Ganyan ang mga RBC mo, tawag natin dyan, sickle cells. Share the same result in our EOFT. So that's why, if we try to determine the absorbance of the hemoglobin for each tube, and then we graph it sa EOFT graph like this, so which do you think between patient C and A has non-lysing RBC? Non-lysing. Patient A or patient C? Okay, A. Kasi ano, tagal pumunta ko. Diba? Medyo nag-skew dito. Kasi ito yung standard. So meaning, this patient C ay merong mga fragile na mga red cells. Like hereditary spherocytes, hereditary lymphocytes, or megaloblastic anemia. Hindi na ba? Yan. Okay. Parang nagtutaan ko yun, di ba? Bakit? From duty ba kayo? Kung nag-aaral? Oo, talaga. Nag-aaral. Kuya, bakit? Meron kayong exam? Dati kami yung para, walang diretso. Ang ginagawa lang, bigyan kami handouts. For 2 hours you read that. Then after that, you will have your exam. Ganun din ngayon?
Sometimes, sir. Pinapabasa lang po tapos.
Okay. Maganda yun, di ba? Oo, gusto mo yun. Kung babasa ka, tapos may exam na. Pero kung nagtuwa ka sa para, tapos may papasa ka rin, no? Ha? Kawawa naman kayo. Hirap na ba kayo sa
Sabay na lang kasi yung parang mag-update. Oo nga, sabi sa akin, sabay yung mag-update.
this erythropoietic anemia. Okay, now so for the RBC metabolism, we have a metabolic pathway known as EMP and SMP. Now the main enzyme under EMP pathway is pyruvate kinase, and then we have the G6PD. Okay. Now if you want to know if you have a problem with enzymes, okay, because if you have deficiency of these two enzymes, the red cells are easily destroyed. You don't analyze them, no. So we can use what we call the fluorescence spot test or autohemolysis test. So yung mga tatlong test natin for metabolic pathway. Okay. Now, so for the G6PD, the principle of this test, no? Kuha tayo ng filter paper. Okay, filter paper. Tapos lalagyan mo ng drop ng blood ng pasyente. So, WT test, then negative control, then positive control. So, lagyan mo ng blood dyan. And then, papatakan natin ang reagent. No? Kunwari, D6PD muna. So, yung ating reagent is containing glucose 6-phosphate. The reagent. So, if your blood has enough G6PD, magtutuloy-tuloy yung reaction up to this point. No? Now, the NADPH will be there, one of the end product of the reaction, and then that will fluoresce under UV light. So kaya pag G6PD okay, enough yung level ng G6PD, then that is what we, then the patient's blood has enough G6PD. So dapat mag-glow, mag-fluoresce under UV light. So pag pyruvate kinase naman, ganito rin, maglalagay ka rin ng blood dyan, but this time, ang ipapatak mong reagent ay yung may content na phosphoenol pyruvate. So if the pyruvate kinase is present doon sa ating blood, then eventually the reaction will go up to this point, and NAD is the end product. This one will not fluoresce. That's why for pyruvate kinase, there should be no fluorescence sa blood para masabi natin na enough yung pyruvate kinase. Nakikita ba? So I hope, no, mag-reflect na to yung mga results ninyo sa mga exams. Okay? Ito naman kakaalaman nyo, kung naintindihan o hindi. Anyway, another is the glutathione reduction. So we can also apply it na yung fluorescence spot test natin. So dito rin, no? So yung reagent naman, ibang nakalagay. Yan. No? Yung ating oxidized glutathione. O ilan? Wawan. Nato ka rin. Puyat ka rin. Kakaaral.
Puyat lang.
Kawa naman kayo. Nakawa na kayo. Kaya maganda, dadalihan mo sa winter. Kasi baba niyo yung piling. Pwede na yun, no? Sayang na lang. Ha? Kasi meron lang din yun, no? So, kung maganda yung glutathione reduction capability of your blood, you add that reagent, and then the reaction will occur. So remember, the NADP is the one that don't fluoresce. So that's why here, the blood will fluoresce for 20 minutes for a while, tapos dapat mawala after. Kasi na-consume yung NADPH. Yun, so that is the fluorescence spot test. Okay, now, so what is your answer here? Which of the following may give a false normal result? So the answer there will be, pag hindi nyo alam yung sagot, anong ginagawa nyo sa exam?
Or nanong C daw, sir, sa standard exam. Yes.
Okay, mag-C mali. No?
A.
A, mali rin.
A.
Mali
All
rin.
of the above.
Okay, letter B.
Okay.
Tama yun. Letter B yan. So, all of that
As what's the
will give
picture?
us a false normal. No? So, ibig sabihin, nag-glow kahit So one of the problems with G6PD is that deficiency. If you have exposed the red cell into an oxidant, it will form an inclusion within the red cell. And what do you call that inclusion, if you still remember? Okay, Heinz bodies. So gusto natin malaman, no, kung yung RBC ba ng pasyente talagang kulang ng G6PD. So i-expose natin yung RBC sa oxidant na reagent, and that is acetylphenylhydrazine. So we add acetylphenylhydrazine, and then if there is G6PD deficiency, so it will cause now inclusions of 5 or more. So we call this the Heinz bodies. So what you have to count, how many RBCs ang meron 5 or more inclusions before you report it as positive. So nakalagay naman na rito, pagka more than 32% of RBCs containing that, then positive, but less than, negative for Heinz bodies. Okay? Now, Heinz bodies is not specific for G6PD. Heinz bodies can also be found in unstable hemoglobins. Tandaan niyo yun, no? And also other enzyme deficiencies. So please refer to your manual. What are those other enzymes, if deficient, may also develop into Heinz bodies formation. Pero ang pinakasikat with all of those enzymes is G6PD deficiency. Now, so what are those examples of drugs that if you have that deficiency of enzyme will lead to Heinz bodies formation? So ayan na, makikabisado na lang, Rimap-1, Benazir, etc. etc. So yung Vapamins, hindi yan drug, pero yan ay isang kinakain nila sa mga vegetation. Okay? So what then will happen to your red cell? Masama ba na may mga inclusions yung ating mga red cells, lalo na pag malalaking ganyan? Yes, masama, syempre. No? Pagpasok niya sa spleen, kakainin ni macrophage yung mga inclusion, unfortunately, pati membrane ng red cells madadamay. Kaya paglabas ng RBC sa spleen, nakita nyo may mga kagat-kagat, parang kinagat yung red cells. So ang tawag natin dyan ay white cells. Okay? So white cells. But white cell is not only for Heinz bodies. Kasi may mga abnormal inclusions din na pwedeng makagat ng macrophage tapos magiging white cell. So, tsaka nyo na alam what are those other inclusions na pwedeng mag-lead to white cell formation. Okay? And then of course, it will lead to hemolysis kasi sira na yung red cells. Yan. Okay. Now, what else? Ano pa yung test natin na pwede natin ma-differentiate yung pyruvate kinase from G6PD deficiency? So we have what we call autohemolysis test. So whenever we say auto, it means what? Self, okay, self-hemolysis. So in this case, you will try to allow the red cells to lyse on its own by placing it to a warm temperature. So get the specimen of the patient, expected to have either pyruvate kinase or G6PD. Get the specimen, place it in a warm temperature like 38, 39, 40. If you have deficiency of those enzymes, malalays ka agad. Diyan ba? And early lysis. So, pag nalays ka agad, iisipin mo dalawa. Pyruvate kinase ba or G6PD? Diyan ba? Eh, gusto mo ma-confirm, kuha ka ulit ng specimen dalawa. Diyan. Yung isang test tube, lagyan mo ng glucose reagent. Yung isa lagyan mo ng ATP reagent. And then put it sa warm surrounding. Okay? Or sa 38, 39. 37, ganyan. Ganyan. Now, check for hemolysis after several hours. If the hemolysis is corrected by glucose, no, but not by adding ATP reagent, then this is a case of G6PD deficiency. But vice versa, baliktad, that is pyruvate kinase deficiency. So what do you call the result of G6PD deficiency? Autohemolysis type 1. Pag pyruvate kinase, autohemolysis type 2. Now, meron nangyari na correct yung hemolysis, we call it autohemolysis type 3, both reagent corrected it, and we see that now where? In hereditary spherocytosis. Okay, pero tandaan niyo, ang hereditary spherocytosis, hindi ito ang kanyang test. What is again the test for hereditary spherocytosis? Erythrocyte osmotic fragility test. Nadami lang siya dito. Naintindihan ba? Ganun lang yung autohemolysis. Okay, ngayon, ito naman. So, last test for metabolic pathway. The ascorbic cyanide test is to check your HMP, so not the EMP. So what is the objective of the HMP? If you still recall, the main objective of the HMP is to reduce glutathione, an antioxidant. Kaya pagka kumain ka ng hotdog, kumain ka ng kung ano ng mga preserved foods, hindi nasisira ang iyong hemoglobin because we are protected because of these antioxidants. So we want to know if we have enough antioxidant, meaning you have normal HMP functioning. So what you will do, get the blood, add these two reagents. If the result is brown formation, meaning you have a defect on your HMP. Okay? Defective. Pero pag red pa rin, meaning hindi na oxidize yung blood, then you will have a negative result. So meaning your HMP is normal. So ganun lang kasimple. No? So dalawa lang yung reagent, sodium ascorbate and sodium cyanide. Di ba na? Yun ang tatlong test natin para sa mga metabolic pathway. So we have the fluorescence spot test, we have the yun, saka yun. Okay, now, then let us go with hemoglobinopathy. Okay, hemoglobinopathies are considered to be is considered as the qualitative hemoglobin defect. Quality. Okay, quality ang problema. So, nakalagay na dyan, no, usual cause, amino acid substitution, resultant in instability of the hemoglobin molecules and affecting the shape of the red blood cell. So what happens to the hemoglobin? The hemoglobin becomes unstable. So a very good example of an unstable hemoglobin is hemoglobin S. Okay? Hemoglobin S. Ano ba dapat ang hemoglobin natin? A1 dapat, no? Hemoglobin A1. Now, ano nangyari kay hemoglobin S? Yung beta-globin chain niya, no? Yung 6th position na amino acid, instead ng glutamate, napalitan ng valine. So, making the hemoglobin molecule unstable. Napalitan. O kaya, konting, isang amino acid lang na nagkaroon ng mutation or na-replace. No? Kama nasisira na yung proteins natin. No? Kaya napaka-importante. Kaya yung genes are very strict. No? What should be the amino acid there? Now, so that's a problem, no? with the hemoglobin S. Kaya under siya ng qualitative, yung quality ng hemoglobin affected. No? At marami pang klase ng hemoglobinopathies, hindi lang S, pero yung hemoglobin T, hemoglobin G, hemoglobin E, hemoglobin C, hemoglobin O, ARA, hemoglobin etc. Napakarami yan. Diba? Okay. So collectively, we call them unstable hemoglobin. All of them, the problem is the quality, what we call that, hemoglobinopathies. Now, we also have what we call quantitative hemoglobin defect. Okay? So, example, or what we see is under quantitative hemoglobin defect, that is thalassemia. Okay? Thalassemia. So, we have two kinds. We have alpha thalassemia and beta thalassemia. So, ano ulit ang mga globin chains ng ating hemoglobin A1?
Alpha, beta.
Okay, so dalawang alpha at dalawang beta. Para magkaroon ka ng dalawang alpha, ilang genes ng alpha ang dapat meron ka? Ilang genes dapat meron? Para makumpleto yung dalawang alpha globin genes mo sa hemoglobin, you need 4. Okay? So 4. Kailangan dalawang alpha galing kay nanay, dalawang alpha galing kay tatay. So, 4 dapat. So, ganun din yung beta. Kailangan 4. Para maging kompleto yung set. Dalawa galing kay nanay na beta. Dalawa galing kay kumpara ng tatay mo. Galing kay tatay. Yan. So para ito, were lacking 1 gene. 2, 3, 4 genes. Meron bang tao walang alpha? Wala siyang tao. Meron din yan. Nawawalan ng alpha. Kaya tawag natin ito, alpha thalassemia major. So do you think this person will develop hemoglobin A1? No, kasi wala siyang alpha genes. So ang nangyayari, nagkakaroon ng mutation, nagkakaroon ng switching of the globin formation, and it will develop a new form of hemoglobin. Wala kang hemoglobin A1, sa alpha thalassemia major, mapapalitan niya ng tinatawag natin Bart's hemoglobin or hemoglobin H. Okay? So this is another kind of abnormal hemoglobin in alpha thalassemia major. So sa Bart's hemoglobin, Bart's hemoglobin, meron siyang 4 na gamma globin. Puro gamma. Puro gamma. Sa hemoglobin H, puro beta naman, 4 yung beta. So pag ganyan ang hemoglobin mo, very tight yan, no? Kasi magkakaparehas sila. So hindi magpapain ng maganda yung oxygen. Hindi ba? Hindi katulad ng A1. Yung A1 kasi nag-open close yun, no? Open, close. Open, close. Nagsiswitch siyang ganyan. Alala niyo ba yun? Basta yun na yun. No? Yan. Okay? So hemoglobin H, so sa alpha. Okay, now, pag beta thalassemia naman, wala ito lahat. Pwede ba yun? Pwede. So, mabubuka yung hemoglobin A1 kung wala kang beta? Hindi rin, kasi wala yung beta. May alpha ka, wala ka naman beta. So, ngayon, dahil wala kang hemoglobin A1, mapapalitan yan ng mas maraming hemoglobin F, tsaka A2. Okay? So, that's why in beta thalassemia, tumataas ang F tsaka A2. Okay ba yun? So, sino mas malala? Si alpha or si beta? Sino mas malala ang thalassemia? Alpha or beta? Of course, alpha. Kasi kung alpha, wala kang alpha. Itong F, anong globin genes nito? Dalawang alpha, dalawang gamma. Diba? Kung wala kang alpha, hindi mabubuo yung F. Yung A2, ganun din. Dalawang alpha, dalawang beta. So wala kang choice na pwede. Ito kasi pwede ko mag-deliver ng oxygen, pero not effective. Kaya mas malala yun. No? So this is known as a quantitative. So for alpha thalassemia major, this is the form of hemoglobin that we may encounter forming Bart's or hemoglobin H. While in beta thalassemia major, it will have an increased level of F and A2. So yan yung pagkakaiba ng quantitative and quantitative hemoglobin defects. Now, for qualitative or hemoglobinopathies or unstable hemoglobin, we can screen that if meron nga itong mga ito, no? Hemoglobin S, D, G, etc., yung mga klase ng abnormal hemoglobins by using these two tests, screening tests, known as isopropanol precipitation and heat denaturation. So, nandiyan nakalagay yung principle ng test. No? For isopropanol precipitation test, so get the blood, add alcohol, then EQB na 37. Then if you have normal hemoglobins, precipitation will occur later, mga 40 minutes. So yung blood magiging turbid 40 minutes or more pa. Pero pag unstable, madali siya mag-denaturate, no? Madali mag-precipitate. Kaya turbid na turbid ka at yung specimen. No? Now, pag heat naman, gano'n naman, kuha ka ng blood, lagay mo sa 50 degrees Celsius for 1 hour. Pag normal ang hemoglobin, there's no problem. Hindi masyadong marami yung precipitation, so hindi masyadong turbid. Pero pagka turbid ka agad, or there's a heavy flocculation or turbidity. So that is the principle. Again, this is a screening test. Okay? So one of that, unstable hemoglobin is hemoglobin S. Now, what we want to determine really, other tests for sickle cell anemia. Kasi itong hemoglobin S is sickle cell. Okay? Sickle cell yan. So I've already mentioned to you what is the problem with sickle cell anemia. No? So the beta globin chain is affected. The is place by varying at 6th position, no, of that amino acid sequence. There are 8 clinically significant forms, so nandyan, nakalagay. Okay? So for SS, pag sinabi mong hemoglobin SS, yan ay sickle cell anemia. So, talaga may anemia. Itong mga iba, SC, ST, SL, yan. So that is sickle cell disease. Pagka meron naman kayo nakita sa exam, AS, hemoglobin AS, this is called trait. Okay? Sickle cell trait. So between SS and AS, sino mas malala?
SS.
Siyempre SS, kaya ang pangalan niya na may anemia na. No? So mababa na yung hemoglobin hematocrit. Yung trait, pwedeng normal pa yung kanyang hemoglobin and hematocrit. No? Kaya lang, dahil may S ka, so bawal mangyari sa ito. No? So kung may S ka, either trait, either diseases, or sickle cell anemia, bawal ka bumagsak ang oxygen level sa blood. Why? What will happen to your red blood cell? Bawal ka rin ma-dehydrate. Bakit? Ano mangyayari sa red blood cell? Bawal ka rin maging acidosis because your red cell will tend to what? To become sickle. Okay? Magsisiklin siya. Ngayon naman, kung mag-sickle, ano mangyayari sa iyo? So, pwedeng magpara yan doon sa mga blood vessels natin. So, you know what will happen. The oxygenation here, the blood supply will pick up on that part of your tissue. That tissue or organ will die. Okay? Wala ng oxygen eh. So, ang mga affected organs usually are those organs that do have small vessels like spleen, kidney, but other organs can be affected. No, pwede. Tulad nito, no, affected yung kanyang mga digits, so mamamaga. So, we call it dactylitis. Okay? Yan. So, pwede mamatay yung spleen, tawag natin doon, splenic crisis. Kaya nga, vaso-occlusive crisis, splenic crisis, mamatay yung spleen. Pagka-kidney, mamatay, delikado na, mamatay ka na. Diba? Ngayon, meron din sa mga lalaki known as priapism. Okay? That is, the penis is always erect. Naka-erect lagi yung penis. Okay, you know the physiology of how penis gland nag-erect. No? Hindi dahil may puto yun. Sabi kasi sa akin dati, sir, may puto ba yun? Walang puto yun, no? Bakit nag-erect daw? No? Walang puto yun. So bakit nag-erect? Dahil yung blood pumapasok dun sa main vessels, no? Kaya pagpasok doon, titigas, mag-erect. And then eventually, after na kung ano mang mangyari, nagpa-plastic, babalik dapat ulit yung blood sa circulation. Yan. Pag meron ulit yun, no? Babalik ulit siya. Tapos na, ganun na naman, no? Dapat. Ang nangyari dito, pumasok yung blood, pero dahil may mga ganito, hindi na makabalik yung blood, papunta sa circulation, nagbara na. Kaya laging direct. Kaya ano mangyayari? Kung gano'n, no? Maubusan ng oxygen yan. Yan. Sinaipon ng dugo doon, hindi na nakakuha rin ng oxygen yung blood. So what will happen to the penis gland? So the penis will die. Anong tawag yun, no?
Mamatay naman. Ay salute.
Death of the penis. Okay? Or mawala yun. Mawala. Magkagangrenous siya. Mamubulok, mangingitin, etc. Then eventually mabubulok. Okay, that is one of the consequences of having sickle cell anemia. Okay, so what will be their remedy? Anong ginagawa nila dyan? Wala lang. So, kaya na lang mamatay, no? Okay, sisip-sipin yan, no? Sisip-sipin ng syringe. Okay, susukan drugs to prevent that oxidation of the
Papalaki ng vessel. Papalaki mo na blood vessel natin.
malaki.
Pasok. Oo.
So pwede rin, siguro, kung pwede ka ng ganun. Pero, kaya pagka ikaw, mag-aasawa ka, lalaki ka, at may hemoglobiness ka, no, even though it is just really free, okay? So, bawal kang mauhaw. No? Dapat lagi kang regulate. Diba? Okay. So, anyway, so basta dapat ay, yun, no? Huwag kang mauhaw, huwag kang aakyat sa bundok. Kaya pag may hemoglobiness, bawal umakyat sa matataas na lugar. Kasi kulang ang oxygen level doon. No? Baka mag-breather, mag-sigal yung blood. Now, you want to know kung may hemoglobin S ka, yung patient's blood. We have a screening test for that. And that is your sodium metabisulfite and diethionine solubility test. So, what is the principle? First, of the sodium metabisulfite. Get the specimen, ilagay sample at that reagent, then make a smear and observe under the microscope if there is any change in the appearance of the red cell. So, for example, naging ganito, ang tawag natin dyan, olive appearance. Okay, olive. S-O-L-L. Okay, olive appearance. Now, if you have a olive appearance, so possibly you have SS or AS in your RBCs, but more preferred sa AS yun. Kaya, pag olive. Ngayon, if the appearance is nag-sickle talaga, no, nag-sickle talaga, sickling of your red cells, so more of SS yun. No? Yung hemoglobin ng RBC ng pasyente. So this is one of the sickling tests na ginagamit natin. Now another sickling test, this time you cannot, this time macroscopic, yung kanina microscopic, no? We have to look under the microscope. So this is macroscopic examination because we will just check for turbidity of the fluid. So all you have to do is get a specimen, add saponin. Saponin will lyse the red cell, liberating now the hemoglobin to the solution, then add now this reagent. It will form crystal if you have hemoglobiness. So between the two patients here, which do you think is to have hemoglobiness? This one or this one?
The left.
Okay, ito left back. Yan. Kasi turbid siya, hindi mo na makita yung linya, no? Sa likod. So ito, normal, parang hemoglobiness. Yan. So AS, either AS or SS, and other sickle cell disease may cause turbidity dun sa ating solution. Now, then we have a question here. Which of the following will give a false negative sodium diethionate solubility? Your answer is letter A. Bakit A? Kasi dahil sobrang konti ng hemoglobin, baka may turbidity na hindi mo pa nakita. Kasi konti lang. No? The rest, lagay nyo dyan, high platelet count. No? High platelet count. Ito kasi mga to, it causes turbidity in our plasma. So it may cause false positive result. So those are screening tests for sickle cell. But we want to confirm, this time, you will use hemoglobin electrophoresis. So for hemoglobin electrophoresis, okay, alam niyo na ang principle ng electrophoresis, right? Okay, we'll not elaborate that. So we will allow the protein to migrate at what specific point in a gel medium. So for hemoglobin electrophoresis, this is the pattern of migration that we expect na mag-migrate yung mga different forms of hemoglobin. So ang pinakamabilis na mag-migrate at PHA or cellulose acetate agar is hemoglobin A towards the positive charge or anode area. Okay? So AFSC. Pagka cyclic agar naman, so this is the point of origin. So SNC goes to the positive charge, then FNA goes to the negative charge. So in your midterm exam, I will ask this, no, to answer this question. But before that, so ito naman yung iba pang mga migration pattern ng ating mga other forms of hemoglobin. So for example, you have a question like this, no? So patient number 4 has you have fever, malaise, slight abdominal pain, patient has negative for sibling test. Patient's condition is probably what? Okay, patient number 4, nasa S lang yung kanyang van, no? So, dalawa nasa isip niya. Baka SS yan. Or, other, ano, no? Baka ST, SG, kasi yung D, tsaka G para sa point na lang eh. Kaya baka nito, ay baka hemoglobin D, baka rin hemoglobin G. Or baka combine, no? Hemoglobin S, hemoglobin D. So, sagot nyo dyan B muna. Pero kung bakit may nilagay ako rito, letter C, sickle cell anemia. Will you also answer sickle cell anemia? So, dalawa kasi possibility, yung sickle cell disease and sickle cell anemia. Sickle cell disease kasi ST, SG, so that is a sickle cell disease. So, dalawang possibility. Kaya kung bakit may letter E, B and C, nilagay ko dito sickle cell anemia. So, yung answer will be E.
Pero
Either
sir,
B,
which is the best?
parang best.
Sir,
Dalawa nasa isip mo.
Wala namang ganun tanong sa exam.
Sir, ang best.
Yung which is the best answer.
Siyempre meron, pero ang best doon, dalawa. Dalawa sila eh. Possible kasi. Naintindihan ba? Okay, so yun, no? Naintindihan ba to? So, bibigyan ko yun ng ganito at i-interpret nyo. Is that a sickle cell trait? Pag trait, may A palagi. AS. Kaya kung natin ito, hemoglobin D trait, ibig sabihin, that is an hemoglobin AD. Okay? Kung sabihin trait, may A. Ibig sabihin, may normal na hemoglobin A1 pa. Kaya sa blood niya, may dalawang klase ng hemoglobin. Okay? Yung RBC na iba, containing A1, yung ibang RBC hemoglobin D. Pero pagka SS ka, halos lahat ng RBC mo, puro S. Wala nang A1. Kasi sira yung beta globin chain. Hindi ba? That is the problem. Okay? So before we proceed, which of this patient, 1 and 5 are reference? Reference ladder natin yan. Di ba ganun sa electrolysis may ladder tayong reference? So between 2, 3, 6, 7, 8 patient, which of that is a normal patient? Yung 1 and 5 reference.
Ay, hindi pa lang lang. 2, 3, 6, 7, 8, sir.
Lahat yun normal.
2.
2 lang. Ano ba yung normal na hemoglobin? A. Ayun. Normal siya. A1. Diba? So, ibig sabihin, ang concentration kasi dapat ng A almost 100%, diba? 97 to 98%. So, if you will interpret that, patient number 2 don't have any problem. That is a normal hemoglobin. So, how about patient number 3? What will be your interpretation? Okay, normal ba? Lalo na pagka nilagay ko sa exam niyo. The patient's age is 35 years old. Normal ba na may F ang adult? Okay lang yan, pare. 11-day-old pa lang yung pasyente, so pwedeng merong F. Di ba? Kasi kagaling na lang dun sa group eh. Pababa kasi yung F eh. Dapat pag 1 year, halos wala na yan. Hindi na masyadong mag-effect. So, ito ay abnormal sa isang adult. So, you interpret it as what? Anong thalassemia ba ang tumataas ang F? Diba? Beta thalassemia major. So, possibility this patient has thalassemia. If you want to be specific, beta, no? Beta thalassemia. Naintindihan ba? How about patient 6? Trait, yan. Sino ba yung may trait? Okay, kaya kung nanyanon po, patient number 6, what is your interpretation? Sickle cell, right? Okay. Sino pa? Si 8 ganun din. Yung 7, ano siya? kanyang hemoglobin type. So SC is another form of sickle cell disease. Kaya pagkalagay ko niya, patient number 7, letter B rin, no? Sickle cell disease. But this time you know what is that? SC na kagad. Kaya lang yung isa, STSG, sickle cell disease, dito hindi mo alam. One ba? SS ba? STSG. So that's why if you have another question related to that, so what is your answer here? Si number 4 pa rin. Anong gagawin mo as a medtech? Or what will you recommend? Next step.
I see.
C. Sino sagot ng C? Okay, marami. Sino sasagot ng iba?
Yung natutulis.
Gusto mo, release na lang, no? Sickle cell disease na. Dahil alam mo, possible sickle cell disease. Okay, the answer here is letter C. Kasi you have to confirm, baka sickle cell anemia or sickle cell disease. So, confirm natin. So, yung cyclic agar. Kasi pagdating sa cyclic agar, iba na yung pattern of migration. Maghihiwala yung D sa G, ay D, G sa S. Kaya pagkas na nilagay ko sa inyo, cyclic agar, meron ba sa may S lang? So, ano yung kanina?
Cellulose.
Hindi. Ano yung sickle cell anemia or sickle cell disease? Nag-cyclic agar ka, sa S lang may band.
Anemia.
Sickle cell anemia. Pero pagka meron kang band dito, tapos may band ka sa may point ng A, so yung kanina, sickle cell disease yun. Ako ba? So baka ST o kaya SG. Pero kung natin wala dito sa S, after cyclic agar, nandito lang sa may point ng A, ano yung kanina, yung patient number 4?
Sa A lang, sir.
O sa ila, wala yung S. So hindi siya sickle. No, not normal. Yung patient, nandito siya sa S kanina eh. Sa cellulose acid. Ay sa...
Trait.
No, not trait. So possible, isipin mo, baka hemoglobin D yun or hemoglobin G. Hindi ba?
Opo.
So I hope this is clear. So I will give this kind of exam and then you will interpret, no? So para medyo ano ng konti, hindi ko lalagay ito. Okay, positive, negative, then you have the bonds there. So you must know what are the pattern of migration under cellulose acetate or cyclic agar. Okay? Kung hindi ko lalagay. Pero pagka medyo gusto mo lalagay ito.
Sir, sabi ko gagaling.
Okay, so may tanong ba doon sa interpretation? So madali lang, no? Basta huwag nyo lang kakalimutan yung reference natin, no? Pagka nasa cyclic agar, ito yung pattern ng migration ng reference. Pagka nasa cellulose acetate, no? Ito yung pattern ng migration. Okay, now then we have screening tests for beta thalassemia because as I mentioned, tumataas ang hemoglobin F pag beta thalassemia. So this is a screening test. We have alkaline denaturation and acid dilution test. So for alkaline denaturation, of course, we will use base substance, no? Pag gumamit ka sodium hydroxide, that is BET. If you use potassium hydroxide, that is Singer test. And then the acid we use is citric acid. Yan. Now, so ano principle nitong test na to, no? Red cells that don't have hemoglobin F will be destroyed by either acid or alkali solution. So, masisira. Pero pag hemoglobin F ang meron dun sa RBC na yun, intact pa rin yung ating RBC. So, paano natin gagawin? Get an EDTA sample. Lagyan mo ng either acid or alkali. Lagyan mo. Tapos, after that, you got smear and then stain and look under the microscope. Check if there are red cells that are still intact. So how do you know that? If the red cells are bright red in color. So meaning, these RBCs are containing hemoglobin F. Okay? Yung mga ghost cells, yung mga fatal stained cells, meaning those red cells, ibang hemoglobin ang meron doon. Yan. So, bibilangin natin ilang RBC ba ang INTA. So, meron tayo ditong formula, number of hemoglobin and RBC per field. So, count the number of INTA red cells sa 10 field and get the average. So, for example, you have counted 50 of that na INTA ang red cells for 10 fields. So, how many per field? So, that would be 5 per field. Okay? And then, after that, use this formula to get the percentage of RBC in hemoglobin F. So, all you have to do is number of RBC, this is 5, divided by average number of red blood cell per field. So, kaya bibilangin mo rin kung ilan yung mga nakita mong mga ghost cells sa 10 fields. For example, nakabilang ka ng 1,000 na RBC observed, and then multiply by 100, your answer will be 5% of that is your INTA RBCs na merong hemoglobin F. Is that normal? Of course, hindi. Okay, kapag nga zero yan, pag-add individual. Naintindihan? Okay, so these are some of our screening tests for detection of your hemoglobin F. Is there any question? Now let us go with antibody. So some antibodies are destroying our red blood cells. Okay? Now, there are certain disorders such as autoimmune hemolytic anemia, HDN, and HDR. Okay? So what is the meaning of HDN? Hemolytic disease of the newborn. Pwede rin, ang tawag din nila dito is HDFN, hemolytic disease of the fetus and newborn. No? Yan, how about HDR? Hemolytic transfusion reaction. So all of this condition, the consequence of that is that yung ating mga red blood cells is coated with antibody. And you know that what will happen pag ang RBC mo coated ng RBC, ng antibodies, tulad nito, ano mangyayari sa mga RBC na yan? Ha? Pero may mga antibody, abnormal na natin, pwede mangyari yan.
Kakainin.
Kakainin nyo, macrophages. Okay? Hindi naman bites kakainin ng macrophage yan, kainin nila, kasi may mga antibody. Ganun kasi yung macrophage, parang kala nila, basura, kakainin nila yun. Parang bacteria, may mga antibody, kakainin nila. Okay, so dito dapat hindi. Kasi RBC mo, iba't may antibody. So nakikita yan sa mga conditions like this. Okay? So yung mga pathophysiology niyan, tsaka nyo na alamin. Basta, ito. So gusto natin malaman if there are really antibody attaches to the red cell of the person. So like this, what I'm a specimen, EBD sample ulit. No? And then we add this reagent known as anti-human globulin. Anong itsura ng anti-human globulin? Ganito ang itsura yan. Pag nag-blood bank kayo next step, you will always use this. Okay? So, kaya ang pangalan niya, anti-human globulin, it is an antibody against human antibodies. Kaya antibody against antibody siya. Nakuha ba? Paano nabubuo yan? Para mabubuo yan, kukuha ng blood sa tao, ito-purify yung plasma, kukunin yung immunoglobulin or antibodies, i-inject sa rabbit. Okay? Yung rabbit's immune system will be triggered to produce antibodies against the human antibody. Tapos yung blood ng rabbit kukunin, ito-purify, at kukunin yung antibodies against human antibody. Pagkakita ba? So, meron pa ng host reagent. So, ngayon, anong endpoint ng DAT test? Tawag din yan DAT test, no? Direct anti-human globulin. So, ang positive result, kung meron naman nakapong, magka-agglutinate after we add this reagent. So, magka-clump yung red cells. Pag nag-clump, ibig sabihin, may antibodies na nakapong. Have you seen an agglutination after you put reagents? Yes. Sino nag-blood type kung medtech with ninyo? Sino man nag-blood type? Okay, anong blood type mo? Oh, walang agglutination yun. Sino yung blood type A or B? Yan. So, saan nagka-glutinate? Nakita niyo ang glutination? Yes, nag-crop, di ba? So, ganun din ang endpoint ito. Magka-crop yung mga red cells. Okay, so that is how we do or check if there is sensitization or antibody coating the red cells. This is another picture illustration. Pag meron kaya mag-glutinate, positive reaction, non-glutination, negative reaction. Okay, so another possible problem that we may encounter allowing production of antibodies against red cell is PCH. Okay? PCH is paroxysmal cold hemoglobinuria. So baka malito na naman kayo ha. Yung isa PNH yun. Paroxysmal nocturnal hemoglobinuria. Ito PCH, paroxysmal cold. The problem here is the development of auto-anti-P. Okay? Auto-anti-P antibody which is IgG antibodies with biphasic characteristic. Okay? Yan, biphasic. So ano ibig sabihin ng biphasic? Pag meron kang ganyan, yung ating mga antibodies, ididip lang sa red cell kapag malamig yung temperature. Like for example, 0 to 4 degrees Celsius. Okay? Then lysis of this red cell will happen if we incubate the blood at 37 degrees Celsius. So it was discovered by these two scientists. No, si Mr. Landsteiner at si Mr. Donat. No? Ano nila? May kaya tawag dyan, Donat Landsteiner test. Kaya itong antibody na to, no, pagka tinanong sa inyo sa board exam, what antibody is known as Donat Landsteiner antibody? Your answer will be auto-anti-P. Auto-anti-P. Yun din yung pangalan ng antibody na Donat Landsteiner antibody. So, bakit nag-trigger na nag-develop ka ng ganyan? Pwede mag-trigger yan pagka ikaw ay nagkaroon ng syphilis. Alam mo yung syphilis?
Yes. STD.
Sino nagka-syphilis? Paano nagtatransmit? Nagtatransfuse ko, no? Nagtatransmit. What organism causing syphilis? Okay, Treponema pallidum. Okay, Treponema pallidum. So, natin test, no? So, anong gagawin natin dito? Dalawang specimen, kunin mo. Yung isa, lagay mo agad sa 37. The other one, place it first sa ref. Okay? And after that, incubate. So, dapat, ang hemolysis lang ito, no? Pagkatapos manilagay sa 37. Pero pag sa cold pa lang, hemolysis na. So, hindi yun, auto-anti-P. Malinaw, di ba? So those are examples of tests that we can use to detect if there is antibody attacking the red cells. No? So that's why you have a question like this.
Immune hemolytic anemia.
Ang sagot niya. Okay, immune. Pag immune, may mga antibodies. Sagot niya letter B. Ano or auto antibodies. Okay, ito sagot dyan, spirocytes. Lagyan nyo na lang dyan spirocytes, kaka nyo na alamin bakit spirocytes. Marami kasi explanation pang mangyayari dito. No? So, pagdating nyo na sa mga diseases, so it will be discussed to you. Yeah. Now, so let us go naman sa test para malaman kung meron ba megaloblastic. Ano ulit yung nutrients na kailangan natin para ma-prevent yung megaloblastic anemia? Okay, vitamin B12 and folate. So, ang similarity between these two deficiency is makakita tayo ng malalaking cell. No? Macrocytes under the... So, parehas, no? Parehas. Kung ang megaloblastic anemia mo ay dahilan sa vitamin B12, what is exhibited under the microscope is the same. So you will see the same thing. So you don't know which of that is vitamin B12 or folate. So you want to know if that is vitamin B12 or folate. So we can do microbiological assay. So for microbiological assay, you can use a microorganisms known as Eugenia gracilis at saka Lactobacillus leishmani. Okay, and you have Lactobacillus casei.
And late money.
Leishmani. Itong mga to,
Ginugulo. Link. Di ba sir, link? Okay.
Magtawag ng LICE.
okay, itong mga to, para mabuhay sila sa medium, kailangan ng vitamin B12. Ito naman, folate. So, ang gagawin mo lang dyan, kuha ka ng dalawang, kuha ka ng serum ng pasyente o kaya plasma ng pasyente. Kuha tayo. So, separate mo sa dalawang test tube. Yung isang test tube, mag-inoculate ka ng gracilis. Okay? Yung isa, mag-inoculate ka ng casei. Alam niyo ba mag-inoculate, di ba? Parang broad medium yan. No? Plasma or serum ng pasyente. And then incubate overnight at 37. Then wait for growth. So how do you know pag nabuhay yung bacteria or organism dun sa broth? What you will check? The turbidity. Okay? So for example, this is a Eugenia gracilis tube. And this is Lactobacillus casei. Between the two, no? Sino ang nabuhay? Yung casei. Diba? So dahil nabuhay ang casei, anong deficiency niya? Vitamin B12 or folate deficiency siya? Ha? B12. Kasi kinabuhay yung gracilis. So kulang yung vitamins doon sa plasma ng pasyente. So that is how we differentiate if the cause of megalodactylia is due to either vitamin B12 or folate. But if, for example, both of that, no growth, no turbidity, so there is a combination of vitamin B12 and folate deficiency. Now, for vitamin B12 and folate deficiency, you do the oxidative suppression test, also an bone test. This, the specimen used here is bone marrow cells. No bone marrow. And then, if there is deficiency of either of those two, there will be an increased uptake of radioactive thymidine sa deoxyribonucleic. So, pag increase ang uptake, no, ng mga bone marrow cells, deficient ka ng either vitamin B12 or folate. Okay, increased uptake of this radioactive thymidine.
For both yun, sir.
For both yun, no? Next, we have another special exam known as Schilling's test. This is to assess level of intrinsic factor. So as I mentioned to you earlier, for normal absorption of vitamin B12, you need what? Intrinsic factor, di ba? Kailangan natin yung gusto natin malaman kung may intrinsic factor, maglagay ka ng so first, inject vitamin B12 known as flashing dose. Then, mag-ingest ka ng radioactive vitamin B12. What is the reference value? The reference value dapat yung ingest mo ng radioactive vitamin B12, more than 7% of that should be excreted out in the urine. So what is the urine volume? 24-hour urine collection. No? 24-hour urine collection. Yun lang. Pagka mababa rito, ibig sabihin, wala kang intrinsic factor. Okay? Then, we have hemoglobin A. Saan makikita to? Alpha or beta thalassemia? Yung hemoglobin H. Alpha, di ba? So, sa alpha thalassemia. Gusto natin malaman kung may hemoglobin H nga. So, ang gagawin lang natin, di ba nag-mix na kayo? Di ba? Pwede mo sa ikaw?
Hindi ba, sir?
Di ba?
Kasi pa lang.
Ano ba section mo? May kailan kayo? Monday. Kaya lagi walang pasok kasi. So anyway, natin stain para ma-stain lang natin yung hemoglobin H is 1% BCB. So the color of a hemoglobin H inclusion is dapat bluish green ang color. So that is the end color. Pag ganon, so hemoglobin H yun. Ngayon, para mag-increase yung yield of positivity or positive result, which of these RBCs you will choose to stain with BCB? Old RBC, young RBC, or senescent RBC? Okay, young RBC. How will you know na young yung mga red cells? Paano kung pipiliin yung mga batang RBC? Madali lang yun. Get the liquid spirit, siyempre babagsak yung RBC, di ba? Yung pinaka-anchor most part of your red cell, nandun ang mga young. Kaya aspirate mo yun, then apply into your slide, smear, and then stain. Okay? So, ganon. Pagka gusto nyo makita yung mga okay, now, do you have any question with this? Siyempre wala, kasi iba na yung ginagawa nyo. Nag-review na lang yung iba ng parasitology. Okay, so anyway, so eto, ano sagot nyo na lang dyan? Okay, shillings. Ano yung EOFT para sa inyo? Okay, yung Ham's test para sa ha? Okay, fluorescent spot test para sa ayun na yun. Oh. Okay. Ganyan lang yung mga tanong. Yung ba ganito lang? Oo. Yan, ito habang yung Ham's test para saan? PNH. Yung Donald Steiner para saan? BCH. Para sa mga points. So just review, no? Ito. Letter D. D.
Sagot ko E.
Para sa mga to, sa sequence na to eh. Patay tayo na sa liquidity. So evaluating RBC metabolism either of these two. Ganyan na yung mga tanong natin. We have any questions? Special test? So some of that, I think hindi ko na-mention kasi wala rito. No? So you have there in your manual. So just read the manual. No? Na meron mga test doon. So last will be eosinophil count. No? So for eosinophil count, the objective there is of course to know if you have an increased level of eosinophil. So alam ko na pagka may eosinophilia ka, isa sa mga nangyayari ay mayroong parasite. Tulad ng mga inaaral nyo ngayon. So pag may larval infection, doon ang topic nyo na sa para. Paborito ko rin yung para eh. Nakikita mo po lagi.
Nasa Philippines.
Plasmodium. Nasa malaria wala kayo.
Nasa Pupors.
Ba talaga?
Yung training ko, malaria po.
Pero sa lab, mga mulati na. Dati kumuha pa kami ng Enterobius. Enterobius vermicularis. Yun yung nangangating kwet ko. Mga bata pa kayo, nangangating mga kwet ko. So di na kayo pinakuha ng gano'n. Sa mga, kasi common yan sa mga, mga spotters. Yung dikit-dikit yung bahay. So punta kami doon, may microscope kami, molekta kami sa mga bata. Scotch tape sa bako. Ito namin yung kwet ng mga bata. Scotch tape. Scotch tape.
Kumali yung bata, sir.
Oo, kaya yun nanay. Kala doktor kami. Dok, ito naman yung anak ko. Kaya ito, doktor. Kasi kami nagdala kami microscope. From there, tingnan namin kung positive. Kasi natin namin kasaralan. Nakikita niyo doon kung merong peg ng Enterobius. Pagka sinerte ka, makikita mo yung babaeng worm ang inginto. nanginginom siya. Dami niya ang eggs. Unti-unti tumalo sa sisa. Minsan kung na-check mo, kunin mo yung form. Pero minsan, mabilis siya. Naiiwan lang yung mga eggs. Okay? Huwag tayo napunta. Kasi natin, tataas siya. So ngayon, we can do counting, we can do direct method. Actually, the principle is the same with RPC and WBC counting. The only difference is, of course, the diluting fluid we use, kailangan malize lahat ng cell except the AUC field. Kasi yun ang bibilangin ko no? So ito yung mga different diluting fluids natin. And then, ito yung mga counting chamber, iba sa UV power. So meron tayong spare semi, meron tayong push placental. So iba sa UV power na ginagamit natin for normal counting. Okay, so sa spare semi, ito yung square, no? Ganito yung tsura. Sa push placental, ito. So bawat isang square na to is 1 micrometer. Kaya ito has 2 millimeter by 5 millimeter by 2 millimeter depth. Okay? So 2 millimeter depth. Yung UV power ninyo, ang depth nun ay 0.1 millimeter. Ito 2. So mas maraming volume ang nakukuha na ginagamit natin. Sa push placental, 4 by 4 yan. No? 4 millimeter by 4 millimeter and 2 millimeter depth. So the same principle, you will aspirate the blood using your Toma pipette, specifically the WBC pipette. Then, aspirate the diluting fluid and then you charge it. The RBC comes na kayo, diba?
Yes, sir.
So you already know this. Then look under the microscope, locate for the square, and then you will see only eosinophil. Kasi yung mga diluting fluid na ginagamit, sinisira lahat ng cell except the eosinophil. No? Mabibilang ng maayos. That's why this is our formula. Eosinophil counted times correction for dilution. If you use Toma pipette, the dilution is 1:10. Okay. Correction for volume, if you use this first semi, just put the 4 there. And then this is times 10 to the 6. Ayan, no? Times 10 to the 6. For example, your result no, is 0.105 times 10 to the 6 per cubic millimeter. Ayan. Or microliter. Ay, 105 pala. Sorry, 105 times 10 to the 6. We want to convert this into an SI unit. Just move the decimal place. So that will be 0.105 times 10 to the 9 per liter. Okay, so that will be your eosinophil count. So just refer to the reference value of what should be the absolute count of an eosinophil before you say that the eosinophil count is increased or decreased. So we have a reference value. So eosinophilia sa allergic reaction, sa parasitic infection. Pag eosinophilia, Cushing syndrome. Okay? If you have any question, inilisan ko na para kapag-review na kayo sa gusto yung reviewing subject at matulog na yung iba. Okay? Si Sir Rupert, ang maraming tawag ko. Nasa Lagero Series. Sabi ko ba Sir Rupert, hihirapan ba